Thank you very much. My name is R.J. Simonds, and I'm pleased to be joined by my friend and colleague, Florence Ngobeni-Allen, to talk to you today about the aspect of mothers and children and HIV. In particular, to tell you and to give you the background information about an important story that we're in the middle of, which is eliminating AIDS in children around the world. First, to answer the question of why this is a story, and why is it that preventing AIDS in children and eliminating HIV new infections in children is part of the triad of the AIDS-free generation of providing treatment as prevention, male circumcision, and preventing mother-to-child transmission of HIV that you'll be hearing about throughout the conference. Well, the answer is that children make up a substantive part of the epidemic. This shows the latest data that just came out a few days ago about the number of new infections in children, the number of deaths in children, and the number of children living with HIV. And you can see that, that children represent a substantial part of the epidemic worldwide. Children, almost all children who get HIV infection transmitted from their mothers. So understanding HIV infection in children and addressing it requires understanding HIV infection in women and addressing that. And the problem is that in many countries that are hardest hit by the epidemic, there's a large population of HIV-infected women who are becoming pregnant, who are then putting their newborn children at risk for HIV infection due to the biology of this. And you can see that there's a number of countries that have, first of all, that around the world there are about 1.5 million pregnancies to HIV-infected women, so that's the target population for eliminating AIDS in children. And you can see that there are several countries in Southern Africa where the prevalence of HIV in women is as high as 1 out of 10 women, or even as high as 1 out of 4 women who are pregnant in those countries. So this represents the target population and where the prevention efforts are addressed. So what I'd like to do is just to briefly walk through 3 stories, and fortunately they're success stories related to they're the backdrop for eliminating AIDS in children and the movement that we're in now. The first is a research success story. Through sustained research over the past couple of decades, we found a lot out about HIV transmission to children, and we've translated that into effective tools to prevent transmission. The key to this slide is several points that early research found out. First of all, most children born to HIV-infected women, it turns out, do not get infected, even if you don't do anything. And that's what these about 2/3 of children will not get infected born to an HIV-infected mother. And so we're off to a good start in terms of trying to prevent infections. But unfortunately, about 1/3 of the children will become infected if nothing is done about it. The second point is that the timing of infection is very important. And what the early research found was that most of the infection was happening late in labor or around the time of delivery or through breastfeeding. And so those became the target points for, if we're going to stop transmission to children, that's when we have to be intervening, before the children are at risk during those periods. The third thing that we found was that children tended to have a higher chance of getting infected if their mothers had lots of virus in their body. And that was a key to designing the interventions that turned out to be effective. The thought was, this is now 20 years ago, the thought was if we could reduce the virus in the mothers, we could reduce the risk of her transmitting to the child. And so the first major breakthrough in this area, in fact, one of the first breakthroughs, prevention breakthroughs in the HIV epidemic, occurred back in 1994 when a trial done in the United States and France showed that if you gave a mother an antiretroviral drug, and this was the first drug available to be able to use to fight the HIV virus, that by giving that drug to the mother during her pregnancy, intravenously during her delivery, and giving the drug to the baby for 6 weeks, we could reduce the chance that the baby would become infected down to about 7 or 8%, down from the higher rates. And so this became a major breakthrough. It also taught us that we could prevent transmission through the use of drugs. And this is actually now what's being at the heart of treatment as prevention now. By treating people, you can also prevent sexual transmission as well. So taking this research finding and adapting it to the developing world was the next challenge, because this intervention studied in the United States was not feasible to be implemented where the health systems are weak, and it cost too much money to be to be implemented widely in poor countries. And so over the next decade were a series of studies that adapted this regimen to become simpler and able to be implemented in areas where the health system was not as strong. Fortunately, even simpler versions of this approach worked, and they then formed the basis for the second story that I'm going to talk to you about, which is the public health success story. So we now have a tool, and this tool is as effective as the vaccine tools that we were just hearing about. But the challenge then now is having this tool is how do you turn that into public health progress? The first point is that a strategy, a common sense strategy, if you think about it, was designed to prevent infection in children, and it has 3 components. One, preventing mothers, women and men from becoming HIV infected. If adults are not infected, they're not going to have an infected baby. Second, preventing unintended pregnancies in HIV-infected women. If a woman does not want to become pregnant, help her to plan her pregnancies and reduce the number of HIV-infected children that way. Third, if a mother is HIV-infected and pregnant, using the tools that we talked about, implementing them and reducing the chance that the baby will become infected. So this is the overall strategy in play. And what we saw in the United States when implementing this is a dramatic impact. This graph shows the number of cases of AIDS in the United States in children who, from 1985 up until 2007. And you can see that the number of cases was rising dramatically in the 1980s. The intervention that we talked about was implemented here, and then there was a dramatic decline over the subsequent years as this was implemented in the United States. With this success in the United States, and with the research that showed that a simpler version of this approach could work in developing countries, it set into motion a set of activities, including a call to action that the Elizabeth Glaser Pediatric AIDS Foundation initiated to begin to implement this in Africa and Asia. Columbia University followed suit. The US government, through an effort prior to PEPFAR and then as part of PEPFAR, made preventing mother-to-child transmission a key component of that. And the reauthorization of PEPFAR in 2008 had as a special focus PMTCT, which you'll hear about, that's jargon for preventing mother-to-child transmission of HIV. So this became, because of the science and the experience, it became an integral part of the prevention approach through the US government and through other sources. And the progress that we've seen now is very impressive. This graph represents the coverage worldwide of the antiretroviral interventions among HIV-infected pregnant women. And you can see that from a very low coverage back just 8 years ago of 10%, there's been a steady march upward in the coverage around the world. This steady march of coverage, combined with also the recognizing that the glass is still half empty, and knowing that we can do more, and knowing that in countries like the United States we can virtually eliminate new cases of HIV infection and AIDS, has led to a new effort that was begun last year to have a global movement to eliminate new HIV infections in children and keep their mothers alive while doing so. And so you will hear during the conference various aspects of this global plan. It was launched last year. It is co-led by Ambassador Gooseby of PEPFAR, who leads PEPFAR, and Michel Sidibé, who leads UNAIDS. It's notable in that it's integrally promoting African leadership and getting this done, recognizing that that's a key element to success. It's integrating these HIV interventions into the existing maternal and child health systems, so they will stay strong and won't be and will be part of the overall systems going forward. And also, very importantly, as newly mobilized the private sector to get engaged through a business leadership council. The hope is that, and the trajectory for reaching virtual elimination of new infections in children is shown by this graph, where at the time of starting the global plan, we had begun a decline worldwide in number of cases. The data that just came out this few days ago from last year show that we're here. So we've made the turn on the trajectory, and we're destined to, or we're hoping to keep going down the trajectory to get down to virtually zero infections. So we know this is possible, but the stories that you'll hear about and the key and the place where we are in this story is in figuring out how to overcome the many barriers that it takes to implement even a relatively straightforward intervention like this. And this includes reaching full coverage, as we talked about, strengthening the maternal and child health systems that these services are delivered through, engaging communities to support women and to encourage women to utilize the health services, maintaining the political commitment of leaders to support financially and to support policy-wise, create favorable policies, provide support for women and children to engage with the system over the number of steps that it takes to achieve the interventions, bringing in men into the equation so that men can be supportive of their women partners in going through the system, innovating to overcome many of these barriers, and then, of course, funding and the human resources needed to do it. The final story is moving this from the systems to the personal level, is that we're seeing success at the individual level. And I'm going to hand the microphone over to my colleague in a second, but to introduce that, want to now take this to the personal perspective of what does a woman need to do if she wants to prevent her child from becoming HIV infected. And this shows the sequence needed of getting antenatal care, HIV testing, receiving and understanding and processing, having a HIV result. If infected, a variety of services, beginning medications, getting laboratory testing, getting partner testing to protect the partner, other family members, et cetera, delivering in a health facility, and then even following delivery, engaging with continued drug support, infant feeding support, family planning, getting the baby diagnosed, et cetera. So there's a number of steps that women need to take to take advantage of these resources. And so I'm pleased now to let you hear directly from someone who's been involved in this effort from South Africa. She just arrived in town yesterday, and she will tell you way better than I could about the personal aspects of the story. So, Florence, please.
Is it good morning?
Yes.
Good morning.
Good morning.
I think I'm demonstrating that Africans can tell time, isn't it? But that's not the truth. I'm jet lagged. That light is killing me, so I'll keep blinking like I've got an eye problem or something. So good morning. My name is Florence Allen, Ngobeni-Allen. I'm from South Africa. And I've been an ambassador for the Elizabeth Glaser for the past 16 years. I've met the Elizabeth Glaser through a program that we were running at Chris Hani Baragwanath Hospital. as an HIV positive mother, but as a counselor. I have been through the system, through the cracks. I've learned a lot, but the key things I've learned were personal more than anything else. 16 years ago, I was diagnosed with HIV through my daughter Nomtunzi, who then passed away at age 5 months old. Through that moment, it was the most difficult part of my life, but I guess through the work that I started doing at Krisani Baragwanath Hospital, counseling women about the prevention of mother-to-child transmission, helped me heal a lot. One of the key things that I learned was to share my story as I'm sharing my story with you today. We did not have access to ARVs back then, and the ARVs I could share were my personal story of how to survive with HIV after losing a child or when you're during pregnancy. I have soon after that got married a few years later, and 10 years later after losing my daughter, with my husband who's HIV negative, we got educated about how we can conceive safely to have an HIV negative child. We were blessed with our son Alexander, who's turning 6 next week on the 25th of July. And a few years later, through the education of child spacing with HIV, we were blessed with another son called Kulani. That's Kulani there at the back. I like the slide that Dr. RJ showed us of what kind of systems the woman needs to go through to access services to keep themselves healthy, but also to make sure that their children are born without HIV. I've gone through that process, but I still believe that there are women who still don't know or who do not have that kind of care in hand to make sure that they are receiving all the services they need to receive. As a person who has been blessed with 2 children who are HIV negative and still looking quite healthy, I've never been ill in my life ever since living with HIV for 16 years. The only illness I'm experiencing is colds and minor skin problems and just fatigue most of the time. I've also developed some chronic illnesses due to side effects with the long-term ARVs that I've been taking. But except that, the system and the programs that have been started with all our partners, as mentioned by RJ, is that through the education and involvement of people living with HIV and engaging communities in policy making, it is possible to eliminate pediatric AIDS. And I am proof of that it is possible. So through the work that they have done as Elizabeth Glaser and as an ambassador, through the engagement of people living with HIV like myself, it has proven that if women are given all the tools that they need, the tide can be turned around. Today we need to talk about a cure. We need to talk about research in terms of vaccine. And we've heard from the other speakers that it's possible. But I also want to give hope to the floor and everybody else who's attending this conference that we are nearing the end of AIDS, but there are still challenges. And the proof is here that people can access these medications and be healthy and be productive, but also contribute in the fight of HIV/AIDS. So I also would like to thank the organizers of this event. I think it's very nice that we get journalists to be, given the information relevant, but also to meet people like me and be given a chance to speak to them. So I thank you very much and thank all the people who have attended today to come and hear from us. Saying that, I will open up the floor for questions, if ever there's anyone with questions. Thank you very much. Yes, sir.
Yes, I have 2 questions, actually, and I think you both may be able to answer them separately. Dr. Simonds, I'm engaged in a project on raising awareness about depression in black gay men. And one of the things that I've come across in my research is that as of 1990 or in the early 90s, there was the discovery that children being born with HIV developed or had issues as they grew in adapting to medication. So how can you please talk to us about children being born with HIV and as they grow, how they adapt to the various types of medication they've been needing to use? And you may be able to answer the second question, but maybe Florence might be able to talk to this. The other issue that is coming out in the research about pediatric HIV and AIDS is that children born with HIV suffer discrimination, and they suffer stigma because of the virus in how they interact with other children, how they interact with other family members. And so the question then is, how as a mother, given all the stuff that you have to deal with and worry about being HIV positive and bringing up a child, to deal with the stigma and the discrimination that that child has to suffer? And perhaps a third question is that what has also come out is that there is a lot of developmental disabilities in children who are HIV, that they suffer developmentally compared to their other children. So there are kind of like three questions there.
Thanks. I think I will answer the issue of stigma and discrimination on children born with HIV. You know, it's a very interesting aspect because one of the key things that we're seeing is that through the introduction of PMTCT drugs that were given to women in the times that I started working at Chris Hani Baragwanath Hospital, there are a lot of children now who were born with either HIV or who are now at the childbearing age, or at least they are, they are teenagers. So it is an issue that the key things that they have to deal with is that when you take a child to school the first time, you have to take their medical records with you to start school. And sometimes if they have to start school, they may also have to be taking ARVs that needs to be taken at various times when they're school. So we have seen in South Africa where children have been, not eliminated, but have been told they can't attend a school because they're HIV positive. So, but the schools and through the advocacy groups that we have tried to intervene in either in a legal aspect or as a community to educate that school and say you cannot, it's infringing human rights to refuse the child to go to school because of their HIV status. The other issues is that as a mother who's HIV positive, I still have to disclose to my children that I have HIV. And I guess if a child is born with HIV, it's a different thing. We see a lot of anger and denial in children, which also causes a lot of withdrawal and a lot of frustration whereby children are fighting with their parents, and we lose them through the system because they don't want to be involved. But the other thing is they may not have been told why they're taking medication by their parents. So disclosure is still an issue with children. And those who know, there'll be denial, there may be anger and depression and withdrawal from society. Saying that, I've never seen a child who've killed themselves because they're HIV positive. But also I've never seen a community stoning a child because they're HIV positive. What you see is the normal issues of stigma and discrimination in the community where people, if they're not educated enough, they will say, this child is going to infect our child. We can't have our children going to the same school with this child. We've also seen cases whereby the families are also embarrassed about their own children being HIV positive. So they will either keep it from school, or if it gets out, it gets very nasty. We don't have enough programs that are attending to psychosocial issues and mental issues with children born with HIV. And I think it's something to take up and learn maybe from this conference, from those who are doing those programs, to see whether what's the success story when it comes to dealing with mental issues and stigma and discrimination with children. But it is a need that we work on it. I still don't know how I'm going to disclose my status to my kids. My children, the elder one who's 6, the other time he said, "Mommy, you like taking your medication, don't you?" I said, yes, baby. And he said, it keeps you healthy. I said, yes, I'm taking this medication to keep me healthy, and you need to take your multivitamins. So we don't know exactly how the effective way of disclosure and helping kids to deal with these issues. So I think it's something to look forward to learn from the other groups.
Thank you. I'll just make a couple of other comments related to your earlier question. You really hit on a couple of the key issues of HIV infection in children. As my first slide showed, there's 2.4 million children living with HIV, and while we're talking about trying to prevent new infections, there's still a large number of children who are infected, and they're particularly where the epidemic was hit earlier. They're now growing up. The treatment is working, children are growing up, but they're confronting problems in addition to what we just talked about of long-term medication use, and they often, sometimes do need to change medications because they quit working or because there's side effects. There are long-term side effects of some of the medications that need to be watched and managed. There are long-term effects of the virus that need to be addressed. You mentioned developmental delays. The virus does affect the brain, and children do have developmental issues. They have other organ issues as well. Also, as Florence mentioned, children are growing now into a period of sexuality where they need to be addressing all the other issues that adolescents deal with in the context of taking medications, having an infectious disease, having a chronic medical condition. So there are a large number of issues to be struggling with and to be that are in effect byproducts of our success of being able to treat children and have them live longer. But we're seeing unfolding experiences in order to address these. So thanks for raising that.
Hello, my question is for Florence Unjansis. I'm from South Africa. She's also from South Africa. I want to ask you a question that relates to the health minister in South Africa. He just announced that we've reached an all-time low of mother-to-child transmission. And there's been a lot of skepticism about the results he just produced a week ago, or a few days ago, to say. As an advocate for women's health and women's reproductive health, are you also skeptical about the recent results that have been given by the minister?
Thank you. I think the answer I have will not make you happy. I'm very happy with those results, and due to the fact that I've been involved in mother-to-child transmission for a very long time. One of the key things that I would like to say is that for the first time in South Africa, we have a health minister who's hands-on. A guy who gets his team to run with him into districts and talk to people about what needs to be done. So I applaud him for all that. So I think the stats that he came with are really accurate. In South Africa, we're nearing the nearly 2% transmission rate, which we're hoping for in year 2015. And I guess through all the efforts that have been done, yes, he is right. We have challenges whereby there have been some few policy issues that were made without consultation of people living with HIV, especially mothers. And one of the key things that's coming out from the ground is the whole exclusive breastfeeding thing with pregnant women who are HIV positive. But I also believe that through the engagement of civil society and educating civil society and the actual NHI approach that's coming of the re-engineering of primary health care in training community caregivers to actually be the first people to go out and talk to communities, that he's actually, I support him on that.
I'm from India. My name is Krishna Rao. I'm a television journalist. This is regarding the media-related query. We have guidelines issued by the National AIDS Control Organization and the Press Council. For the adults and the children living with HIV, the written consent must be taken for the adults, whereas for children, either they're affected or infected, please don't show. But recently, for 1 year, we were running a campaign about the stigma and discrimination, And the children said their nutritional status is much better, their CD4 count is higher. It's like any other disease like cancer and TB. So why should you show discrimination? Please show us. We want people to see we are playing, we are happy. And this is the kind of images now we are getting. So as a mother and as an organizer, do you think they are right in demanding that they should be shown on television?
Well, thank you for your question. I think, one thing I've learned about HIV in the 16 years that I've been living with it is that it's a trial and error thing. So most of the time we think we have the right answers, and then when we implement the programs, we learn that actually we were wrong. So I would say the answer to that question would depend on the knowledge of people in India, and also the knowledge of HIV, but also the acceptance of people living with HIV in India. So I'm not quite sure, but I know that there are a whole lot of human rights issues there too. I would say that every individual, before they are shown on television, they need to give consent. And secondly, they need to understand the impact of that. In terms of when they go back to their community, will they be accepted? There also needs to be backup in terms of support groups or counseling, or after, homes where people can go if they're experiencing violence, because we have seen a lot of domestic violence with disclosures like that. We've seen people being rejected. We've seen people going through depression because they suddenly were shown on television. So I would say make sure that all the services that are required to provide people after disclosure like that is provided. We will never succeed on stigma and discrimination by showing people on TV. I think what will help us to combat stigma and discrimination is to accept, first and foremost, that HIV can infect anyone, and get everyone to test, and not have certain class of people to test, black people, white people, prostitutes, and all that, but just have everyone to test. And the acceptance and the language we use for those kind of things will also help us with stigma. The other thing is that if we're saying we're testing people, they need to have access to medication and programs. So if we provide those things, then it's cool. But you as a program director, if you are, I'm not sure, if you're also to test and come up with your HIV status publicly before you ask the others to do so, it might also help. But I don't have all the answers for you.
I want to thank Florence and our great team. I can make one final comment. We have in your thumb drive a journalist guide that addresses all of these issues and many more that you have access to. The latest data from UNAIDS that I referred to are not here, but you can find those on our website as well. So stay tuned. Yeah, absolutely. So look for us. Thanks.